Guys, Ms. Woodruff here. Today I'm going to talk about bedside report. So bedside report is something that has been more commonly done in the last few years, and it has a very good importance. I'm going to talk a little bit about why we do bedside report, what kind of things are included, and then I will do an example for you so that you can be prepared. Keep in mind that this is how I do bedside report, but your instructor may look for something different, so always check in with them to see what they're wanting from you or expecting from you. Um, so it used to be that we would do report at the desk or just kind of walk in the hallway and do report. And you may still see this done at a lot of facilities, but the best practice way that is enforced in a lot of hospitals is doing it at the bedside. And you may think, well, why does that matter? And there's a lot of those questions. Well, what if there's two patients in the room? Or what if there's family members in the room? Or do we really have to talk about the patient in front of them? And those are all valid questions. But the reason that we have to do bedside report is because there's so many things that are missed. And I can tell you from my own personal experience that there's times that I've walked into a room after getting report, like sitting at the desk, and like the person didn't have a central line, or there was stuff that was very different or wrong than different than what the nurse had told me in that report a few minutes ago. So it's always good to put eyes on the patient and really see if what they're telling you is matching and consistent. It also helps so that you don't forget or miss anything. And it's a great opportunity as well to check any lines, tubes, drains, devices that may need checking on a regular basis and kind of handing off. Additionally, if they have any medications that are infusing, that you can check those and make sure that they are infusing correctly at the correct rate and that their access and everything is intact. So a lot of the principles of giving a bedside report is you want to tell them very pertinent information about the patient. You want to let them know pretty much like a good way to look at it is you want to tell them about the past, what's going on right now, and where's the patient going. And there was someone that was a mentor to me early in my journey as a nurse that always told me, like, you should always be thinking about where the patient is going and what's that next step you can do to help them get in the direction that they need to go. It's really our job as nurses to be advocates. And so, it is my job to go in and complete tasks. But if I get really task-based, like 9 o'clock I do this, 10 o'clock I do this, I'm not really thinking about, okay, but what next? I'm helping the patient get through the day, but what's their next step? How can I help them take that next step? Maybe they need to get in touch with a care coordinator. Maybe we need a consult from a different physician. Maybe there's some other help that they need. But I should always be trying to help get them in that next step or next direction to get in the help that they need. So when doing a bedside report, making sure that you're, starting with a lot of information about like the patient's history. And I like to tell it kind of like a story. Like I try to kind of tell them like, okay, so the patient was at home this many days ago. And, I kind of talk about what happened, what brought them to the hospital. And I talk about their medical history, anything that's pertinent that the nurse might need to know. If the patient has a really long, extensive medical history, I'm not going to list everything. I'll just sometimes say, hey, they've had a lot of surgeries. You may want to look at that. Also, if they've had like a torturous course, like sometimes at JPS, like if a patient's had a major trauma, sometimes they could have upwards of 15 to 20 surgeries. They could have been there for months. So sometimes we even print a page where like, here's their history. Here's everything that's happened since they've been here. You can look at it if you want. But usually I just try to list like, if it's something that someone has a big history, I try to list major injuries or things that are still a problem now versus things that are fixed, not a problem, etc. You want to bring up all major history, especially chronic diseases and things like that, like diabetes and heart problems. Bring up a lot of those major problems. When you're talking about what's going on right now, I usually do I talk through my full head to toe assessment. It's not that that's necessary. You can also just talk about abnormals, but I think it helps sometimes to do pertinent normals. For me, it just helps kind of check off in my head that I went through it and that I know what's going on with the patient right now and that I don't forget anything, but that's completely up to you. But you should talk somewhat about your assessment. You should have somewhere in there, hey, here's what I'm assessing, or here's any abnormalities. I also kind of talk about anything that happened that was pertinent during my shift, whether it was something with their family, something with a physician, a change in their condition, any calls I needed to make, any problems that we had. And that next step is it's kind of like that S bar that I was talking about in a different video, where at the end, we always do the recommendation, or I'm kind of saying, hey, here's what they need. Here's labs or tests that are still pending. Here's kind of the next step that we're going to take. So that's kind of an overview of how I do a report. So now I'll kind of just give you an example and take you through one. And I'm going to just make it up off the top of my head. So, forgive me if I have any disorganization here, but I'll just kind of give you an example. And this is kind of what I'm expecting expecting from my students. I don't expect it to be perfect because I know that it takes time and it's nerve-wracking. And real quick before I start, I was going to say, I think one of the best things that helps me is to have, a sheet that works really well on my Google Drive. I have a bunch of report sheets, so feel free to check out some of those. And then if you're in my class, I also have them on our Canvas. So, definitely utilize those because I think if it's like for me, it's not that like a lot of times for me, I can say all this stuff without even having to look at a sheet. But when I first started, I really needed that sheet to help organize my brain. What do you call it? So for me, let's say, okay, so this is Mr. Sam Douglas. He is a 53-year-old male. He is a full code. He is not in isolation and he is allergic to penicillin. He was admitted to the hospital on the 27th of November. He was originally at home. He was having some shortness of breath and difficulty breathing. He came into the hospital and he was diagnosed with pneumonia. He has MRSA in his, not MRSA because he would be in isolation. So I'll just say he has Staph aureus in his sputum, and he has been receiving antibiotics and is responding pretty well to them. So that kind of tells the story about like how he was doing. So then I would move into, he has a medical history of COPD. He also has high cholesterol. He has hypothyroidism and GERD. He is, taking regular treatments at home, and he stopped smoking about 20 years ago, which is just the pertinent stuff because then we had COPD. So anyway, so I've talked a little bit about, his story about why he came here, his medical history. Now I'm going to talk a little bit about why he's here today. So then I would go on to say, he's not having he has a productive cough. He's able to use the suction, or I've taught him to cough it into a napkin. He is having some chest pain when he coughs. I did teach him to split today. Neuro-wise, he's intact. He's not confused or had any confusion issues. He has Perla. He's not having a lot of nasal drainage, just that productive cough. He is taking an adequate fluid, and I've been encouraging him to drink more fluid to help thin his secretions because his secretions have been thick. Respiratory wise, he's on 2 liters nasal cannula. That's what he wears at home as well. And his lung sounds have been, crackles in the upper and diminished in the lower. He does have a barrel chest from his COPD and does utilize pursed-lip breathing and tripod position to help him with his exhalation. Cardiac wise, he has S1, S2. He has 2+ pulses in all of his extremities. No cyanosis or signs of decreased perfusion. He's got good capillary refill. Gastrointestinal system. He is on a heart healthy diet, and he hasn't had much of an appetite. I've been mostly just giving him snacks. He really prefers the chocolate pudding over the Jell-O, and so that's sometimes stuff that I can get him to take down. I have been encouraging him to take Ensures. He's not a really big fan, but he said he'll keep trying them and maybe have a little bit of them since he's not eating very much. Talk to him how important nutrition is. His last bowel movement was yesterday. He is on stool softeners for that. And urinary system, he's able to urinate in the urinal. He doesn't have very good activity tolerance, so while he can get up and walk pretty safely, he gets really tired and winded, so we've just been using the urinal. Physical therapy is working with him to help him with that. Musculoskeletal wise, he can move all extremities. He does have some weakness in his legs, and like I said, he doesn't tolerate activity well, so he needs his oxygen when he ambulates. I did put an extension on his tubing. He uses a walker to get out of bed, usually just standby assist, and if he has to get up and have a bowel movement, we've been using the bedside commode. When it comes to skin, he doesn't have any skin breakdown. He was starting to have a little bit of redness on his coccyx, so I did tell him that we need to make sure that we're turning every 2 hours, protecting his skin well, and then he needs to reposition in bed when possible. I have been encouraging him to get out of bed and sit in the chair for meals. He is married. His wife comes by and visits him regularly. His mom also calls and checks on him sometimes. And he has a brother who lives out of state who's been calling. Um, what do you call it? The plan for him is to continue physical therapy. They might do outpatient pulmonary rehab with him. His antibiotic is going to be switched to oral today from IV. And by the way, thanks, that reminds me, he has 2 peripheral IVs. He's got a 20 gauge in his right lower arm and a 18 gauge in his left AC. He doesn't have any other lines and tubes. What do you call it? Aside from switching the antibiotics over to by mouth, he also was asking the doctor for a cough suppressant or some Mucinex, something to help with his cough and getting stuff up. So if you could follow up about those, his labs this morning, everything looked good. There was no abnormalities. His electrolytes were stable. Yeah, I think that is about it for him. So yeah, so that's probably wasn't a perfect report, but that just gives you an example. And you see, I try to tell it like a story. I include stuff that happened before. I try to talk about patient preferences, let them know like who's involved, you know, the family and stuff that may be involved and those next steps. Now you may be sitting here in your head saying like, how did she just like say all that stuff out loud? You know, I literally in my head, as I was saying that, was imagining my report sheet that I use at work. And that really helps to organize my brain. So like I said, doing a lot of this stuff, and you're not expected to memorize when you do report at the hospital. All you're expected to do is to read from your sheet, talk to the other person. You are expected to be knowledgeable about this patient. You may be saying like, man, like I'm just a second semester student. How am I supposed to know all this stuff about my patient? When you go in and do a full head to toe assessment, you should know a lot of these things. You're supposed to own your patients. This is the semester. I really like you guys to go out there and start taking complete care of that patient. So really working on trying to get to know your patient, know their preferences. You know, I think probably one of the only things I just thought about that I didn't bring up is whether they bathed or not. I always like to tell them that. So I'm kind of letting them know about that status, if there's any new consults, new doctors, or if anyone's following them, like maybe this patient, a pulmonologist is following his care, something like that. I might bring that up. But yeah, it's really just, and again, it doesn't have to be perfect. And, you know, like there's some things I probably could have skipped. I could have just talked about abnormalities, like talked about his respiratory assessment and stuff, but I think those little details count, and not all units have techs or other people. So it's always good for the nurse to know how the patient gets up, how they use the restroom, how they've been doing. You know, you may be asking with the bedside report, what about those sensitive topics? Like what if the patient, like I had a patient the other night at JPS who, had a bad accident, and they've been kind of out of it in multiple procedures, and so they aren't aware that their husband passed away in the accident that they were in. So they were, you know, still under the assumption that their husband was alive, and they did not know yet. They hadn't asked, you know, we were waiting for them to become more awake and not confused to tell them about that. So that's not something I'm going to say right at the bedside. So there are things I try to do, the pertinent details, check all the lines and tubes, do that at the bedside, make sure everything's secure, the patient's safe and doesn't need anything, because in the beginning of the shift it's really busy and I might have stuff to do to get ready, so that way that I know the patient's good for a little bit and make sure they don't need anything immediately, kind of like do rounding on them while you're doing that. But then once we're done and we go back outside or go into the next room, that's maybe a more appropriate time to pull them aside and be like, hey, they've been having problems with depression lately, or hey, like lately we've been having issues with this, or family can't decide on what to do next. Like if there's something like really private, I can say that stuff different. It's not that I have to say everything at the bedside, but I need to go in and put eyes on the patient. I need to make sure their equipment, their devices, and everything is safe. And I need to make sure that they don't have any acute needs at that time, and that pretty much what the nurse is giving me is exactly what I'm receiving. Because believe it or not, I've actually received report on a patient and then gone in and I received report on the completely wrong patient. Like they gave me report on, I don't know who it was, but it wasn't that patient in the room, different gender and everything. So just keep in mind that it's really your responsibility when you are taking over responsibility for this patient, to put eyes on them, make sure there's consistencies. Because, sometimes, especially if you work med surg, that nurse might have not have been in the room for hours before that, checking on that patient. So if there's any changes, you always want to check on them, because, it's really your responsibility to know that that patient's safe and taken care of while they're under your care. So anyway, I hope this helped to kind of break down and show you a little bit about what a bedside report might look like. And I'll see you for the next one.